Good morning, everyone, and welcome to this symposium with live case entitled Myval transcatheter heart valve Optimize Patient Outcomes with a Novel Design, Data, and Daily Clinical Practice. This is a session sponsored by Merrill. There is a lot of content, there is a lot of work, so I ask you to be participant and to pay a lot of attention because we will, during and before and after the live case, we will have a lot of information that might interest you. I am Flavio Ribichini, and with me the spokesperson, Professor Patrick Serrais. The case will be performed from Toulouse by Nicolas Dumontet and Didier Cheche. Our procedural analyst is Nishan Ganjil, who will be working on the CT analysis, and discussants are Ignacio Amat, on my left, a good friend, David Hildrich-Smith, another good friend, Carmine Selvarai, Darren Walters, Niels van Rooyen. And we have guest speakers, Ronak Delewi, is she here? Not yet, Salvatore Giordano and Marcus Castle. So, on-stage medical coordinator Joshua Wilcox. With that presentation, I think I will ask Professor Serrais to introduce some important highlights of the trial performed with the Myval. 1 year subgroup analysis of the Landmark randomized control trial.
Okay, 1 year subgroup analysis of the Landmark RCT, Myval series versus Sapien and Evolute on behalf of all the investigators who are listed on this slide. This is my conflict of interest. I will be short. This is a prospective, you know, the Landmark 1 randomized multicenter open-label non-inferiority trial. It is severe native aortic stenosis requiring TAVI, per the 2021 ESC EACTS guideline. We had 768 patients, the Myval series, the majority, the Myval, some Myval Octapro, 384. We had the Sapien, Sapien 3, Sapien 3 Ultra, 192, and we had the Evolute R, Pro, Pro Plus, and Flex. And we are looking at the clinical efficacy endpoint per the VARC3 consensus, and we report the 1 year at this meeting. Now, the clinical efficacy is the composite endpoint of all-cause mortality, all stroke, hospitalization for procedure or valve-related causes, and the quality of life deterioration by minus 2.5 point of SF12. We have this complex stratification in type of bioprosthetic valve dysfunction, for instance, fibrosis, that's the valve deterioration, valve dysfunction, that's the mismatch, thrombosis, and the endocarditis. You have the second level, which is the hemodynamic valve deterioration with 3 stages. This is an example of the stage 3, a mean gradient above 30 millimeters of mercury. And then you have the clinical valve failure, valve-related death. I have to give the credit to the clinical event committee who did this very difficult task to adjudicate the VARC3. I will be very short on the baseline characteristic. You see here evenly distributed. It's a randomized trial, age, gender, body mass index, NIA class 3-4, STS score, echocardiographic finding, classical, and then multi-slide CT finding with in aortic annulus area 470 in the 3 group, and some small incidence of bicuspid, 6-7% in the trial. Let's start by the aortic regurgitation mean pressure gradient, 1.6% of moderate of more regurgitation in the Myval, 2.3 in the Sapien, and 4.3 in the Evolute, and as you could see, there is no statistical difference. If you look at the mean pressure gradient at 1 year, 9.5 millimeter of mercury for the Myval, 10.5 for the Sapien. There is a p-value there, and then 9.5 for the Myval and 6.5 for the Evolute. There is a highly significant p-value. If you look at the effective orifice area, it looks quite similar, 2.11 in the Myval, 1.95 in the Sapien, highly significant, and then Myval 2.11 versus 2.25 for the Evolute, highly significant. Here you see the freedom from all-cause death, all stroke, and procedure valve hospitalization. The number are 87% for the Myval, 86.9% for the Sapien, 86.9 for the Evolute. You see the hazard ratio, which is close to 1, and the p-value for the log rank also close to 1. If you go to the component, freedom from all-cause mortality, Myval 92.8%, Sapien 94.2%, Evolute 91.6%, no significant difference in p-value or in hazard ratio. If you look at the freedom from all stroke, 94.3 for Myval, 96.3 for Sapien, and 96.8 for Evolute. Again, hazard ratio are not significant, and the p-value for the log rank also. Finally, the freedom from procedure valve hospitalization, 95.7 for the Myval, 93.6 for the Sapien, and 95.6 for the Evolute, also not significant. One word about the quality of life, the decrease of 2.5 points of both physical and mental between the pre-procedure and the 1-year follow-up, 8.8% for the Myval, 14.1 for the Sapien, not significant. Myval versus Evolute, 8.6, 8.8. So if you put together the freedom of all-cause death, stroke, procedure valve-related hospitalization, and the quality of life deterioration, the outcome is 80.5% for the Myval, 75% for the Sapien, and 79.7% for the Evolute. It's quite simple to draw the conclusion. Myval series demonstrate comparable clinical outcome at 1 year compared with Sapien and Evolute series respectively. And the Myval show higher AOA than Sapien but small than Evolute. This is published today in GACC. And I have to say that the next challenge of MeriLife is the Landmark 2, which is going to target the moderate aortic stenosis. And the moderate aortic stenosis, there is 3 other trials finished or going on. It is a mixed bag of patients going to the severe aortic stenosis, but it's also a group who can deteriorate in terms of cardiac deterioration. So this is the people who will be in charge of this trial. We will have 389 in the Myval treatment and 389 in the optimal medical treatment. And we will again follow this patient for 10 years. It's a trial which is sponsored by MeriLife. It looks simple to say the echocardiographic inclusion will be a Vmax between 3 and 4 of a mean pressure gradient versus 25 and 40. And you see this is the patient exclude, but as a matter of fact, it's a very complex type of analysis that we are going to get engaged. So we will have as an echocardiographic lab the Corey Lab in Ireland, and we have the great privilege to have Stuart Pocock, our statistician. Now, can Meryl relove the quadrature of the circle that's working with the cardiac surgeon, the interventional cardiologist, the echocardiographer, and the heart failure expert? MeriLife is a holistic company which will resolve the quadrature of the circle. Thank you very much.
Thank you, Patrick. Dave, any burning question to Professor Surais?
Yeah, Patrick. I noticed as the slides went past, there was a slight discordance, maybe, between the valve area and the mean gradient. So the mean gradient was like 9.5 for the year, which is not dissimilar to the Sapien, but the valve area was significantly better. And was there any explanation that you know of for that? Is it just in the valve design?
Yeah, I think that by definition, the supraannular has a larger effective orifice area. It has been shown, it's smart, it has been shown in registry. In terms of Myval and Sapien, there is a difference there. I think at the time of the design in 2019, the attachment of the valve in the Myval was very thin. And there has been, in the meantime, with the Resilia, the fact that they have improved, the Sapien has improved the thickness of the attachment. And that makes the difference, plus maybe the impact of the anticalcic solution on the flexibility of the valve. That's the main reason.
Okay, thank you for this explanation, Patrick. Now it's a pleasure to invite Dr. Ronald THV. She will lecture on the science and design philosophy of the Myval transcatheter heart valve series.
Good morning, ladies and gentlemen. My name is Ronald THV. I'm one of the interventional cardiologists from the Amsterdam University Medical Center. And it's my privilege to talk about the science and design philosophy. These are my disclosures. Now, as Professor Sarai so elegantly demonstrated, we have robust data from the Landmark trial, where the Myval THV series at 1 year was non-inferior to the contemporary THVs with respect to the clinical efficacy endpoint at 1 year. After Landmark, we already also had Compare TAVI, which was an investigator-initiated study from Denmark, where 1,031 patients, all-comer trial, were randomized to the Myval or the Sapien valve. Also here, there was non-inferiority, 14% versus 13% if you look at the 1 year compositive endpoint of death, stroke, moderate or severe AR, or moderate or severe hemodynamic THV deterioration. Effective orifice area was somewhat similar, and pacemaker rates were 21 versus 12%. Also, next to these pivotal trials, there has been a lot of real-world clinical experience with more than 50,000 implants globally already, under 26 publications, and it's now available across 95 countries. 15% of all implanted valves are intermediate or large valve sizes. Myval THV series has been studied in a large spectrum across clinical settings with different patient characteristics. And also, maybe we will talk about that later in this session. There are a lot of upcoming trials with different patient characteristics, and I think it's super important that we move the field forward with more randomized controlled trials. Nowadays, we have moved from the Myval Octapro to the Myval Octapro Plus. It consists of a 2-row hybrid cell design, but where you first had inverted V crown, there's been a minor modification incorporating the V-shaped chevrons, the reversal of the inverted V crowns, and therefore you have minimized THV frame foreshortening and aortic size, and therefore a very precise implantation of the valve. If we look at the size metric, there are 9 available valves. There are larger valves coming, and I'm super interested to follow that. And also in Landmark, as I said, in clinical practice, more than 50% of the implanted valves are intermediate or large valve sizes. Navigate Pro delivery system, it has a usable catheter length of 120 centimeters. It just goes over your old 35,000 guide wire, and it comes on a 30 millimeters balloon up to 26 valve, and a 35 millimeter balloon on 27.5 valve up.
Okay.
Now, super interestingly, the valve is already crimped on the balloon, so you no need to do this in the patient. Here you can also appreciate the crimped Myval Octapro Plus already on the balloon before insertion. You can use the proximal and distal areas, but we just aim for mid on the aortic annulus, and then you have a very precise implantation, and maybe we can demonstrate that later in a live case as well. All the valves come with the Python 14 French introducer sheet. An 18 French dilator comes with an additional 18 French dilator, and I also know that they're working on further optimizing this introducer sheet. Lastly, the OctaAlign technique is, I think, a very elegant technique to really make sure we really hit commissure alignment, we don't misalign. And maybe in the live case, I think we can have a look at the CT and really assess how we can orient the valve to the multi-slice CT view. So we have the commercial placed exactly at the mid of the origin of the right coronary artery. Now, this is a case from Amsterdam in the Netherlands, where we use a lot of large cells. Dutch people are quite large, so we need large valves. And here we see a case with a 32 large anatomy valve, and you can really appreciate the precise deployment of the valve. It hits where you place it with minimized aortic valve gradation. Now, the Myval Octapro Plus represents a progressive design philosophy, I think a step forward in predictable and precise deployment of the transcatheter heart valve to minimal foreshortening. And the OctaAlign technique aids to commercial alignment and is novel for a balloon expandable valve. And hopefully we can use this to make a step forward in achieving the lifetime management of TAVI patients. Thank you for your attention.
Ronak, we have one question for you, Ignacio.
Yeah, thank you very much for your presentation, very interesting. So there are 2 commercially available balloon expandable devices, but many other on the way. We don't know how long it will take. So why we should choose this device over others, or in which particular settings you think there is an additional value of this technology?
For me, the fact that it's already crimped on the balloon is really key. It makes it a very safe procedure. You can take it out. I think this is a big advantage. And also the fact that you have the large valve sizes. I think these are 2 important features that we should keep and are very important for the balloon expandable valves.
Thank you, Ronak. Very clear. Thank you very much. And now I will ask Professor Sorais to introduce us to the reality of the case of the day, presenting the patient's characteristics.
So the patient presentation from the Clinique Pasteur in Toulouse is a 67 years old male, so below 70. He has a shortness of breath, NIA class 2 due to severe aortic stenosis, no syncope or chest pain. In terms of cardiovascular risk factors, you have hypertension and non-insulino diabetes. Clinical presentation, weight of 82 kilos for 1.63 meters, so the BMI is on the high side, 30.8, but he's an active individual. So he has for his diabetes the metformin, he has aspirin, atorvastatin, and amlodipine. So the hemoglobin is okay, troponin is normal, the renal function is good with 80 ml per minute. And then if you look at the ECG, is a sinus rhythm, narrow QRS complex, no coronary artery disease, good ejection fraction, 60, and indeed a severe aortic stenosis below 1 centimeter square. You see the index value. The mean gradient is 41. There is an aortic regurgitation moderate, and the systolic pulmonary pressure is 37 millimeters of mercury. Now, what is important when you deal with bicuspid, and you see it's a bicuspid left-right cusp, it's clearly highly calcified. The raphe is highly calcified. And when you consider the bicuspid, it's very important to judge at different level the possibility of anchoring, if I can say so. So strictly speaking, the annulus has a diameter of 23.3. The LVOT is more or less 1 millimeter less, 22.5. And then what you see, the intercommissural distance, about 4 millimeters above the annulus, is 23.5. And you see what is done more and more is the kind of perimeter of this area, which is also 4 millimeters above 20 millimeters. So basically, there are not too much difference between the difference of area. The sinus of Valsalva is 34, the coronary artery is okay. That will be reviewed in much more detail by the next speaker. So in summary, we have a 67-old male, bicuspid valve with favorable anatomy, no major comorbidity. Euroscore and STS score are quite comparable, 1.6 and 1.2%. And there is equipoise between TAVR and SAVR. So the heart team decision was enroll the patient in the Start Young RCT. You will hear more about that later on. Thank you.
Okay. Thank you, Patrick. So it's actually not a heart team discussion, it's an inclusion in a trial because it's a very young patient with bicuspid, very low risk. And before we start the heart team discussion, we will ask Nisham to guide us through the interactive CT analysis of the case.
Hello, everyone. My name is Nishant Gangal and I work in Coventry, UK. So my objective would be to share the CT analysis and perhaps integrate this with some of the procedural goals. Now, because this patient, as Dr. Sarayas mentioned, is 67-year-old, so it's not our usual practice to offer TAVI. And therefore, in this case, we have to be sure that we have low bleeding risk, low stroke risk, low permanent pacemaker risk, a fairly straightforward index valve implantation, and also ensure that we do have options a few years down the line when the index valve fails. So coming to peripheral arteries, the vasculature is fairly clean. There's minimal tortuosity. The vessels have got good caliber at iliofemoral levels. Yes, there is some specks of calcification just below the aortic bifurcation, but even then, the minimum diameter of the right celiac artery is still over 8.5 millimeters. And overall, I would say that this patient has a fairly low bleeding risk, at least from the vascular access point of view. So we are dealing with a bicuspid valve. This is a cross-sectional view at the mid-sinus level. You can see there is a fused left and right cusp and a calcified raphe with some calcification at the tips of the non-coronary cusp. The LVOT is fairly clean, so the valve is calcified, but it's not horribly calcified as sometimes we would expect from these bicuspid valves. But if one was to consider stroke protection, this is the anatomy of the neck vasculature, and as you can see that it's a type 2 bovine arch where the left common carotid artery and the right brachiocephalic trunk have got the same origin. And this is something to keep in mind. But considering low calcification, or in this case, as well as clean LVOT, the risk of a stroke is acceptable. Since he's 67, we don't want a pacemaker. Can we assess this risk on CT scan? Yes, we can get an idea by seeing the membranous septum, as we know that the length or the height of membranous septum is inversely proportional to the risk of permanent pacemaker. It's easy to decipher on CT scan. So once we have the aortic annulus level, we just need to take the crosshair at the junction of the right coronary cusp and non-coronary cusp. And on the sagittal view, you can see this thin portion of septum, and then this is the submuscular septum. So in this case, the height of membranous septum is 7.4 millimeter, which is actually denotes a fairly low risk of permanent pacemaker. Coming to the business end, so this is what we're dealing with. So it's a type 1 bicuspid valve, probably a functional bicuspid valve with a calcified raphe. It's not a very heavily calcified valve, but still has got decent amount of calcification. The ascending aorta in this case, which is very important, it's only 35 millimeters, so it's nowhere near the surgical threshold, and that's why he's equipoised for both surgery as well as TAVI. Coming to the aortic annulus dimensions, so he's got valve aortic area of around 446 millimeters square with annular perimeter of 76 millimeter with mean diameter of around 23.5 millimeters. The intercommercial distance at 4 millimeters above the annulus is around 23.2 millimeters, so it's fairly similar to the aortic annulus, and we know with Bavard registry where they tried to differentiate the bicuspid valves on the basis of these two dimensions, and if the aortic annulus diameter and the intercommercial distance at 4 millimeter above the annulus was same, it's called a tubular or a cylindrical geometry, and here the TAVI prosthesis would be sized on the basis of the annulus diameter. You can have a flared anatomy where the intercommercial distance at 4 millimeter would be bigger than the annulus diameter, and again in this case the TAVI sizing would be on the basis of aortic annulus diameter because the ceiling would be at this point. On the contrary, if you have intercommercial distance smaller than the aortic annulus, this is somewhat called as tapered anatomy, and these are the cases where one can downsize the TAVI prosthesis as the ceiling would be higher up at the leaflet level. Just for sake of completion, so the intercommercial distance at 8 millimeter is 26 millimeters, so it does flare up once we go higher up. The LVOT is smaller than the aortic annulus, which reassures us that the valve won't dive into the LVOT. He's got fairly capacious sinuses with mean diameter of around 33 millimeters, a coronary height of 15 millimeters, and STJ height of over 20 millimeters. So overall, it looks a fairly straightforward index valve implantation. Now, just one quick slide about the coronary alignment. So Merrill perhaps is one of the only valve in the market where you can assess for coronary alignment on the CT scan. And we'll probably go through this after the valve has been deployed, but just to quickly see how to get this coronary alignment. So if this is the aortic annulus, the idea is to draw two perpendicular lines to divide the valve into an equal left and right, and then a horizontal line to divide the valve into two equal top and bottom. The intersection is something called as geometric node of sinus. The next step would be then to connect this geometric node of sinus to the middle of either the right cusp or the RCA. And here in this case, if you then superimpose a clock, one can imagine that it would be roughly at around 11:58 o'clock. Once you've got this angle, when the valve is crimped, the idea is to keep one of the commercial posts at the same angle we have derived from the CT analysis. And therefore, you will have, in this case, 3 commissures at 11:58 and then corresponding at 60-degree angle. The whole purpose is that once the valve is being deployed, the commercial post shouldn't come in front of the coronaries so that you preserve the options of future TAV and TAV. In case of narrow sinuses, we can treat the leaflets and still facilitate further TAVIs.
Okay. Thank you, Nishan. Well, before we move into the operator strategy, I think it's worth it to have a brief comment on the decision. I'll start with you, Niels. This is a young patient, very young patient, below 70, which is the age limit proposed by the European guidelines. It's a bicuspid. I mean, outside the context of the study, would you consider this patient for TAVI, or would you consider the patient for surgery?
Well, I would consider for TAVI, but I don't think I will make a lot of friends back in my hospital in the Netherlands. So the Netherlands is quite clear. Actually, we're more conservative than the rest of Europe. So it took quite some time before we were allowed to decrease the age limit from 80 to 75. So we're now at 75. Within the European guidelines, it's 70. But so for this patient, if it would not be within a clinical trial, this patient would certainly go for surgery. Nevertheless, my personal opinion on this is I mean, we have now data on durability of TAVI, which is very comparable to surgery. So if you consider, I mean, if you would consider a mechanic valve, that's something different. But if you're going to implant a bioprosthetic valve anyhow, I don't see much benefit of doing open surgery versus TAVI,
Okay.
but it's just the regulations. So I think a study like this is super, super important to conduct.
It is, and we have to say that it looks like a favorable anatomy for TAVI. I mean, it's not exposing the patient to an acceptable risk of suboptimal treatment.
Yeah, and it's bicuspid, but it's a bicuspid light, so to say.
Yes,
so
and there is no
you
coronary
have three cusps
involvement.
in that way. Yeah.
There is no disease of the aortic root. There is no associated disease of the mitral valve. So it's a good candidate.
Yeah.
Okay.
Yeah, for sure.
Good. Niels, Darren, any other consideration that you take into account considering the long lifetime expectancy of this patient?
Yeah, look, this patient in my part of the world would be considered for TAVI. We sit somewhere between the European and the US guidelines, and someone who's ideal like this, we would definitely consider for transcatheter therapy, and we would have a shared decision making with the patient. And obviously, patients are going to try and avoid surgery if they can. In terms of the things in our favor here, commissural alignment will be important for the lifestyle planning, and getting a valve with a very good effective orifice area is going to be important. And I think with the range of sizes we have here, we have a chance to optimally deploy the valve for the annulus area. And I think this is a very good candidate, as you said, bicuspid light, no adverse features, relatively uncomplicated sizing, no nasty hostile annulus, and no concerns about the aorta. So, perfect case.
Good. Just to repeat it in case it was not clear, I mean, if there is any important question from you, you can send it to the iPad of Professor Sorais, and we will try to answer your question during the session. Regarding the sizing, Kamarai, is there anything special that you'd like to take into consideration in this case?
I think there was a bit of discrepancy yesterday when we were discussing the sizing, whether it was a 23 plus or it was a 24.5. So for me, I guess if it's a bicuspid, I'm always more comfortable with doing a balloon sizing. So I would use a minimal diameter balloon. Like in this case, we should be using about 20 to see if there's any leakage, etc. Before we decide on the final sizing, so-called. I mean, we'll deal between 23 and 24.5. The other question I would like to ask is that the coronary height was 14.5. Usually, I mean, is there a lower one? I mean, it's like a total 14.5, or because what's the right, what's the left? Do we have that? Do we have the right and the left?
Yeah, so both left and right coronaries are at around the same level, 14.5 to 15 millimeters.
Okay. Thank you.
Okay.
I think we have to move now, and Flavio will tell us what is the operator strategy.
Yes. So, as you know, the case will be transmitted from Toulouse. The operators are very expert people, Nicolas Dumontet, Didier Cheche. And of course, we want to apprehend from them the challenges of TAVI in bicuspid aortic valves, and this is an excellent example, to capture the key steps of TAVI with the Octapro Plus prosthesis, and to discuss the contemporary options for young and low-risk patients with severe aortic stenosis. So it's a very specific case. The case will be performed under conscious sedation. We will discuss about the need or not of cerebral protection that has been organized for this patient. We will see a pre-dilatation with a 20 millimeters balloon. The pacing during the valve deployment will be performed directly on the wire on the LV. And as I said, there will be a cerebral protection with the Sentinel at the size of the valve that has been selected. It's an Octapro Plus 23. This is a team in Toulouse that I guess might be ready for starting the live case transmission.
Hello, Flavio, can you hear us?
Yes, Nico, we hear you and we see you very well.
Great. So, welcome to Clinic Pasteur for this live case. We heard your discussion about our patient, the patient we're going to treat, and we must say, Didier, we're totally online about your discussion. So what I propose is that we directly dive into the case by just explaining where we are so far. So, as you said, regarding our strategy, the patient is under conscious sedation. And we already performed some arterial accesses. On the left femoral access, we have a 6-strand sheath housing the pigtail, will help us to guide the implantation. On the right femoral access, we performed the ultrasound-guided puncture plus a 1 prostyle placement for the pre-closure, and I've inserted the Python sheath. While on the right radial artery, we have a long 6-strand sheath housing the Sentinel device, and we'll be able to come back on that point if you want us to explain the rationale in that situation. So if you now focus on the fluoroscopy, here is the Python 14-strand sheath insertion. The Sentinel device, Didier, was a little bit challenging to implant, as you detailed, because of a bovine arch anatomy. But after a few attempts, it was possible to implant it. And Didier, this is the first angio in the equivalent right-left cusp overlap view we have. Can you comment on that?
Definitely, it's super important. It's all into the small details, and getting a proper projection is the very first step. Even though that's the type of projection that we use even for our tricuspid case, it's even more important for a type 1 left-right bicuspid case, because we could nicely isolate the fused leaflets on the right part of the screen, meaning on the anterior side of the anatomy, while on the left part of the screen, the posterior side, we have a pigtail that sits nicely at the bottom of the non-coronary leaflet, so it's going to be a very good landmark. Sometimes you have calcium there. And what is quite important, Nico, is the amount of regurgitation that we have for this patient. So it's a mixed disease with a predominant stenosis, but significant regurg.
Yeah, and maybe last observation, Didier, is that we confirm what the CT showed us, meaning the calcium burden at the level of his valve is not too important.
Exactly.
So our plan is just now to proceed with the case while starting to cross. And meanwhile, feel free to, of course, ask any questions or ask us for any comments.
Yes. Thank you very much, Nico. This is very clear. You have 30 minutes to perform the case, and so we can start with some questions. I will start with Ignacio. Ignacio, it is your same strategy to prepare the vessels, 2 femorals, 1 proglide, or you have something different in these young patients?
Yeah, for the vascular access, my standard practice is 1 prostyle, and very often we have to add angiosyl, and off-label we keep a parallel wire, so in case the angiosyl fails, we have another chance to close them.
So you always have a protective wire?
Not a protective wire, but in parallel. Through the sheath, we have 2 wires, and we put the angiosyl on one and keep the other one next to it, just in case.
Good. And Dave, femoral contralateral access for doing the angiography, is that your practice, or you prefer to have it from radial? In this case, we have the Sentinel, so we should go from the other one.
Yes, biradial works very well. We did that through the whole era of using the Sentinel throughout the BHF Protect trial. We did biradial and femoral, of course, for the main access, and it works very well.
Flavio, please, maybe we just come back with you. As you saw, the crossing was okay with a regular combination, and we are now recording the hemodynamics that I think you have on your screen on the bottom left.
Yes.
Didier, comment about this?
So that's something that we do on a routine basis for every patient, every single device, whether it be balloon or self-expandable one, because we believe there is a value into the hemodynamic assessment. So what we get here, it confirms that we have a high peak-to-peak gradient that is above 30, averaging 40 millimeters of mercury. And then we have a quite nice aortic wave with a nice diacritic notch, but the diastolic aortic pressure is quite low. It's only 35 here. Speaking about the amount of regurgitation that we have, it's going to be all about streamlined TAVI with a fluoro guidance. So we need to assess the AR at the end. So here what we can say is that we have a quite nice discrepancy between both diastolic aortic pressures and the LV and diastolic pressure. And the heart rate is about 56. So we keep this matrix in mind. It's going to be our basis for comparison after the the deployment of the valve. So Nico, you're going to move across with the Safari Small. Meanwhile, maybe Flavio, you've seen that Nico, as an experienced operator and using that cusp overlap technique, could cross easily with the combination of an M-Platz left one and a regular Teflon-coated wire. Would you propose to the audience another combination, let's imagine that it's a little bit more challenging? What would you recommend?
You mean to cross the aortic valve?
To cross, yeah.
Yeah, that's a very good practical point. They did it in cusp overlap. This gives you an impression. If you stay very close to the pigtail, who is in the non-coronary cusp, you follow with a straight wire. That direction is the easiest way. Is there any comment from you guys from the panel? Do you do the same thing? You prefer other incidents?
Yeah, cusp overlap is very useful. Usually when it's challenging, we will change the catheter or change the wire for a Teflonated wire or polymeric wire to cross, but sometimes we can also put the J wire from the stiff side inside the catheter to orient it better and modify our curve, or even use a coronary wire or whatever that's more advanced, but there are several things we can do to cross in challenging cases, like bicuspid can be sometimes.
Mm-hmm. I see that you are ready to perform a pre-dilatation, Didier.
Yeah,
that's
so
right.
Maybe we can, exactly, Flavio, and maybe for some colleagues who want to know more about that, we can just briefly describe the way we pace over the metallic wire. So, as you know, you need to use your metallic wire in contact with the left ventricle as an electrode, and it has to be insulated by a catheter, here namely the balloon catheter. So we connect to the skin with one crocodile clamp, and to just simplify things, avoid to puncture yourself, we just bite the skin at the level of the incision where we put the local anesthesia, and usually the patient don't have electrical pain. And on the other side, where the metallic wire extrudes from the insulation of a catheter, we connect the other crocodile clamp, and this is the usual way we do it. So of course you need to test that, so let's test that and test the quality of pacing. 180, it's okay.
That's great.
Pacing off. So it works. So it's also a good rehearsal, because especially for balloon expandable valve deployment, you want to be sure that your pacing will be really, really of good quality. So the BAV is a good rehearsal for that. So Didier, let's go.
Yeah. So Nico, just one thing that I did was to remove a bit the pigtail. So maybe if you want to just bring back the pigtail to identify where is the annular plane, so we are nicely across, and then we can bring back the pigtail above the balloon to be able to inject. Yeah, please, Flavio.
Yes, well, very practical point for our colleagues. Did you put the stiff wire on the M-Platz, or you like to put it on a pigtail, or is the same?
Here the size of the left ventricle was enough to nicely accommodate the natural shape and bend of the M-Platz left one, so we did it through the M-Platz. But if you want to do it extremely safely, switching for a pigtail before that,
okay.
I think.
Am I wrong, or
so
already with the wire you have a larger QRS?
Yeah, you're
Maybe.
right.
Okay.
You're right. So that's a nice observation. Okay, let's go for the.
So let's go for the BAV.
Okay, Nico, we follow you.
Pacing on. Okay, Didier.
So inflation and injection. Okay, let me deflate, and we can nicely see how posteriorly displaced is the balloon, which is always the case with this bicuspid.
Do we always need to pre-dilate this valve, guys?
For bicuspid, I would say yes.
For bicuspid.
If there is a strong recommendation, I would say yes.
And for the Octapro?
Not necessarily. It depends on the degree of calcium that you have. Direct TAVI is easily achievable with the device, so I won't say it's systematic. It depends on how confident you are with the device, as it behaves, and how the degree of calcification.
Didier, maybe one technical comment based on how this BAV was done, and also thinking about the upcoming valve deployment. Mainly because of this mixed disease and the aortic regurgitation, and you see that on the image, and the balloon had this kind of parachute effect.
Yeah.
And as a result, as a first operator, I had really to act on the action I had on both the stiff wire that I pushed to be applied on the other curvature on the anatomy and also on the balloon. During the inflation, I had to actively push on it in order to stabilize it, and something we'll do again for the valve.
Yeah, and this is super important, your comment for the valve. So maybe very briefly, if we can just focus on the device, because maybe not everyone is familiar with the OctaPro Plus. So it's just an evolution of the OctaPro with a redesigned external sealing cuff, as you have nicely seen, with these octagonal cells interlacing. But to make it brief, we have the nose cone that is designed to cross very easily. That's why, Flavio, most of the time we don't need to pre-dilate. You see the nice transition with the balloon. The valve is crimped onto the balloon, and we nicely, not the positioning markers, but the markers of the balloon, and the positioning marker is going to be somewhere around the sealing cuff. We have a loader, and then the catheter that is extremely flexible. So we, as operators in Toulouse, we tend not to use the flexing ability of this system, and we tend to advance like that because it's super flexible.
Okay.
Maybe one thing we should mention also is that before to proceed with this valve deployment, we dilated the sheath.
Yeah.
It's inserted with a 14 French dilator, and as you see here on the screen, before to start, we dilated it with an 18 French dilator, as you see. So Flavio, we're now ready to insert the valve.
Yeah, Nico, that's good. But before we implant, Darren has a question regarding the sizing of the balloon you used to pre-dilate in this bicuspid.
Yes, Didier, you want to just comment on the balloon size in this case? What did you choose and why in terms of balloon size?
Yeah. It was that's a very important comment, Darren, which we chose a 20 millimeter balloon, meaning close to the minor axis of the annulus at baseline or slightly above that. We want to be conservative, but it's another way. If you want to test the movement of the raphe, displacement of the balloon, it has to be large enough, otherwise you see nothing. It's sealed, but you don't really see the movement of the raphe. So we decided, Nicolas and the team here, to use a 20, still conservative, but a little bit above the minor axis of the annulus to be remained on the safe side. And then if we need to post-dilate, it's going to be a different one, but we're going to go for a double tap procedure. So please, Nico.
Yeah, what I propose, if you want, is that we cross the arch, we pause in the ascending arch before to cross the valve, just to comment on the landmarks.
Perfect.
Because I don't want us to stay too long obstructive in the valve with this regurgitation, and then once we will be in the valve, we will be committed to a deployment.
Okay, makes sense.
For you?
So let's cross. So we're not going to flex. The idea is really to remain on the external curvature. You can see how the guide wire is bulging.
And now let me advance a little bit more, maybe and record that.
Okay, so what we have, you can see, we only focus now for the audience only on the stent frame. You see the stent frame of the OctaPro Plus device, and you see from part to part of the stent frame those markers that represent the start and the end of the balloon. Inside we have a mid-balloon marker that is a straight line, and then we have the positioning marker that is a little bit thicker. That positioning marker gives us a range of the depth that is available. If you want to be deep, a little bit deeper, you just position the top. The picture, we're going to correct that. We're going to correct that, Patrick. So let's focus on the marker. So the marker, you can put the top of the marker just below the pigtail if you want a deeper implant. If you want a more regular implant, you put the pigtail and the annulus just from part to part of the marker. If you want to be high, you put slightly the bottom part of the marker at the annulus. So it's a way to try to tailor the final depth to the anatomy. Here we have a bicuspid, so maybe we're going to be slightly on the upper range in terms of deployment.
So meaning that the deployment marker, you will put that just at the level of...
Yes. So Patrick made a nice comment that the pigtail was
the pigtail is floating because of the flow.
So let's replace that.
And it was wrapped around. So
will you do the implantation in the cusp overlap or in the tricusp?
Yes. Cusp overlap for every device.
Shall I go rapidly through the panel to know whether they prefer cusp overlap or three cusp for the balloon expandable? Dave?
Yeah, cusp
please.
overlap, definitely. I mean, even though this person's got a membranous septum of 7 millimeters, which is almost unheard of, we want cusp overlap, yes.
Okay, Nacho?
In bicuspid, if it's very unstructured, maybe we implant in another projection, but sometimes cusp overlap, and we check in 3-cusp view, so we do a combination.
Any different opinion from the other?
Now, cusp overlap, especially since it's bicuspid.
Yeah, the only time we wouldn't use that is if there was an extreme angle, which was unfavorable or very obese patient, but mostly cup overlap will allow good high implantation.
Okay.
Okay, so you see we've crossed quite easily, huh? And in this projection, Didier, we had some parallax. So I think what you did is to remove this parallax.
Yeah, slightly. We slightly remove the parallax. If you did need to remove the parallax in more than like 15, 20 degree range, you need to rethink a little bit about the angle.
Yeah.
Here we just moved, it was like 10 degrees, so it's definitely.
So here you see, as I said, for the pre-deal, the valve is quite unstable under spontaneous rhythm. So I will have really to actively work on the equilibrium I have between the push I make on the stiff wire and on the catheter. So I'm currently pushing, sitting with a stiff wire on the left ventricle, and then holding the catheter in place.
And maybe let's space.
Yeah, maybe let's do our angio pacing.
150, please, and then for the deployment 180.
Okay.
Let's
for the
start
angio, let's do angio pacing.
Yeah. Let's have something.
Pacing on.
Pacing on, and you're gonna keep it.
Okay, and record.
Okay.
Okay.
So it could be, maybe slightly, we said the top, maybe a slightly deeper.
A little bit,
a bit
maybe
deeper.
I will go 1 millimeter deep.
Even if the valve doesn't foreshorten much, we don't want to be fully supraannular. So it has to be 1 millimeter deeper, if you agree.
You still have quite a good contractility of the LV with this pacing. Is that this worries you, or you don't care?
Yeah, we do care. It was so if you heard, we asked Pauline to just pace at 150 to get something that is more stable. And for the valve deployment, we're going to go to 180.
Or
if
even
required
200.
or slightly above, just to get rid of any adverse movement of the the left ventricle.
Okay. And just maybe to avoid any concern, and don't worry if because it's our strategy, we'll leave the pigtail in place during the deployment. Okay, so maybe let's go for 200 at the 100. Ready, Didier?
Okay, we can be deep. That's
good pace.
Okay.
The 100. Okay, inject. Okay. So let's go slowly.
Okay,
it's
let me
stable.
push. Yeah.
Okay, you can put it
more,
in place.
you can go. Yeah.
Let me expand. Let me. Okay, pacing off, and we're going to go for a double tap. Pacing off, thank you.
And it's we can review that, and I don't know if you had the chance to see what we did with our hands while deploying, but here the pigtail moved a little bit during deployment, but we saw that we were diving a little bit, and this is, I think, the advantage of this slow deployment technique that allowed us to push a little bit on the stiff wire to come back to our target position.
It was very clear, Nicolas. We noticed that the valve dipped a little bit into the LV, and you retrieve it. Actually, you didn't retrieve. You said you pushed a little bit the wire, and it came up a couple of millimeters for perfect implantation.
200,
then what I see is you're doing a double inflation.
Yeah.
This is called the double tap.
Always.
The double tap. Yeah.
So it's not a post deal. It's with the same balloon, and I see that you wait a while in between one or the other. Is that the way you do it normally?
Yes, we can do it immediately. I don't believe that there is the timing really matters, but as the recall occurs quite immediately, what we do is to wait to see the hemodynamics of the patient. If the blood pressure is fine, we can do it immediately. Otherwise, we make sure that the patient recovers before. Thank you, Axel. I will let you just withdraw. But this is a very important comment about the timing. When do we do the double tap? It depends on the patient, I would say, Flavio.
Okay. Is there in the panel that does not agree with this double inflation? Do you do it regularly with this valve or with other balloon expandable valves, or you don't think it's necessary?
Yeah, I mean, we do it routinely now.
You do it
probably
routinely?
For the last year or 18 months or so. And certainly when you actually measure it, you can see the recoil of the valve, which is then resisted by the second inflation. So you get a definite increase. We've studied it, in terms of the dimension of the valve. It can be as much as 10%. So it's definitely worth doing.
With the same amount of volume, without adding any volume.
Same balloon, no added volume. And as Didier does, we just wait a few seconds, make sure that there isn't any unexpected complication from our initial implant, and then without doing further testing, we simply inflate again, exactly as they did there.
Okay.
Nice demonstration.
So Didier, part of our routine post-implant assessment is the hemodynamic evaluation, and of course to follow just after the angio evaluation.
Yeah.
So you have here the hemodynamic recording.
We are lucky team here because the heart rate is exactly the same.
Yeah.
56, it's 58, so we can appreciate the same thing. Left bundle branch block, but nothing special. We have the aortic diastolic shape that is really nice with a nice diacritic notch. The diastolic aortic pressure, if you remember, it was 35, 37 at the start for the same heart rate. It's now 53. So generating a bigger difference in terms of diastolic aortic pressure, LVED, so AR index that is definitely in a good range. So hemodynamic-wise, it's fine. The left bundle branch block doesn't impact the hemodynamics. So I guess we can withdraw the pigtail, Nico.
Yeah.
And then we will go for the angio and have a bit of discussion with our friends.
So
what is quite important, what we would do, sorry, Flavio, we will rotate, because we need to assess the expansion of the stent frame in two orthogonal views, because it's a bicuspid valve.
Yes, that's very important. And we have a look at the two incidences, especially in the cusp overlap, but we have it. The question is, it was clearly demonstrated that there is no residual gradient hemodynamically spoken with the two catheters. Do you routinely measure non-invasively the velocity and the gradient at the end of the procedure, especially in a young with bicuspid?
Simplicity of this thing is
Yeah, we do it routinely, and you see there is always that discussion about the value of invasive hemodynamic assessment as compared to echo. I'm quite simple guy. I would say that echo should remain the gold standard to evaluate these devices, even if there are discrepancies in between devices. But we do it immediately because, to our experience, Nico, if you start with a peak-to-peak gradient like 5, 10, 15, you can be assured that the next day on echo it's going to be like 30, 40, which is not acceptable. So we tend to have like zero gradient, as it was the case here. So even more important, Flavio, for bicuspid, but we do it routinely. So
Great.
let's redo the angio because we were a little bit...
the pigtail was a little bit far.
Thank you, Axel.
Ignacio has a question for
nice.
you.
Yeah.
It was a wonderful implant. Congratulations, guys. I have just a technical question that I wonder myself with OctaPro.
Yes. Hi, Ignacio.
Hi. Congratulations. We saw that there is a slightly early inflation of the balloon on the ventricular side. Do you see that as an advantage, disadvantage, or you don't care during the implant?
I think this is a very important thing that you stress. It's the way the balloon expands. It's going to be different from a balloon expandable platform to the other one.
Let's
you
review
can see new balloon expandable valves, and they all inflate differently. I would say if you want to actively rotate the device and ensure a good commissural alignment, you need to see a separation of the posts. So I would say devices with a balloon that expands from the top first would be extremely easy to correct the commissural alignment. A device that expands first from the bottom is going to foreshorten less, as we see it with the OctaPro Plus, and that's perfect. And so it's all about understanding the behavior of the balloon, and that's super important. You can still correct by the fact that it expands from the ventricle slightly, but even if it was expanding from the top, I still believe, honestly, that we would still be able to correct the depth.
Thank you, Didier.
Didier, we see that there is a little bit of enlargement of the QRS. Do you think this will be transitory? Is there anything, the patient will be monitored in the next hours? What is your behavior in these cases?
Yeah, our routine practice, Flavio, about that is that, of course, the patient will be monitored from now until discharge.
Yes.
for us, a simple QRS enlargement, but with stable QRS duration, is something, of course, we pay attention to, but it is not a criteria for pacemaker prophylactic implantation for sure, nor for electrophysiology study, because we tried that and we studied that in the past and just ended up understanding that it only led to more prophylactic pacemaker implantations. So it will be simple, continuous ECG monitoring, daily ECG recordings, and that's it.
Okay, I have a
So
question
quite
for our...
Yeah, please.
Yeah,
Please go ahead.
Our CT analyst, actually Nishant, asked me to show the cusp overlap image.
Yeah.
And the other thing is you did the analysis of the membrane septum before the procedure. Do you want to comment on these 2 points, Nishant?
Wide, narrow.
While they prepare to close the vascular access.
Yeah,
This one proglide.
Yeah, it's one proglide. So you see usually, and it is what we have, after one pro-style not activation, you still have some residual bleeding. So we're now inserting the sheath of an 8-French plug-based suture device, and we're just assessing the amount of residual bleeding around that.
There is a tiny...
There is still one. So usually you can try to maybe check whether you can gain a little bit. But here, yeah, it's marginal, let's say. And this is what we have, Didier. What do you think?
So I think, yeah, it should be fine. It's a minor bleeding.
I think so.
So at that point, you decide to retrieve the wire.
Yeah,
exactly.
And you close. Okay, Dave, you have a comment on that?
Yeah. I was just going to ask you. I mean, it's a beautiful demonstration, but Nicolas, do you use the ultrasound to ensure that the position of the proglide is exactly right in the artery, or do you not do that at the moment?
No, it really depends on the situation and the anatomy, actually.
Yeah.
It's true that for routine cases or routine anatomies like this one, we don't do. But as soon as you have some atheromatous plaques, and especially those kind of posterior calcified plaques, then I think it's really useful in order to be sure that you will open the foot plates of a prostyle at the correct location and not inside the artery, which is, as you know, reasons for suture failure and complications. So this is what we have viewed from the outside. So no major external bleeding, but of course, we can't be reassured only by that. So we always check by imaging. And usually what we do is just echo assessments. So we look for two things. First, by two-dimensional assessment like this, the arterial patency, no stenosis, which is the case. And you see the pulsatile flow on the artery. And of course, we check with color Doppler that the flow is okay.
Proximal, distal, and we see that it's fine. If you have it distally, it means that it comes nicely from the proximal part. But you can expose the external iliac if you go cranial. And most of the time, at the location of the prostyle, there is a tiny structure that is that is a little bit rounder. But here we have no bleeding, so it's fine. Okay. It's perfect.
Guys,
so this is the way we check.
Before we close the transmission, we will go to the CT analysis in the room. But one burning question is the use of cerebral protection. Why that the decision in this patient? Very low risk, straightforward case.
I think it's a very important and valid point. Maybe I can summarize it like this. We know by the recent meta-analysis of 2 randomized controlled trials that routine cerebral protection with a sentinel device does not reduce the risk of post-TAVI stroke at the acute phase. This is a fact. But what we don't know, especially for such patients having long life expectancy, is what will be the impact on the long term of a systematic silent cerebral infarct that are seen by MRI, by the debris that are systematically gathered by the filters when you analyze what you have in the filters. And to that question, the recent randomized control trial does not answer yet. simply because it's a long-term outcome that was not the primary endpoint of those trials. So we felt that for this patient having long life expectancy, because there is a potential doubt that those silent cerebral infarct could harm on the long term on the cognitive function. And because also we've learned from the trials that the placement of a sentinel does not harm at the acute phase. So for all of those reasons, we made that choice for our patients to protect the brain.
Great. Thank you. Thank you very much, guys. Excellent demonstration. Perfect results. Perfect timing.
Very nice discussion. Thank you.
You are a certainty. Thank you very much. See you later in the next case. So we have some minutes to address the point of the membranous septum and the distance of the valve, or any comment you want to have. Okay.
I was just going to comment about the left bundle branch block. I mean, I was very surprised to see it, and it will.
Was
sure,
unexpected. Huh?
Yes, it was
Young
unexpected.
patient, high implantation.
But I'm sure it will disappear, because I think all that's happened is the left bundle has got concussed slightly by being punched by the wire in the balloon, and it should disappear because the valve implant is at pretty much annular level.
I also think so. I mean, but is there any detail we can get from the CT? I mean, is it a short, a long membranous septum?
So the membranous septum, we know that there is only sort of limited data, but if the height or the length of the membranous septum is less than 3 millimeters, then there is a very high risk of permanent pacemaker. But it's not just the height of membranous septum. The baseline ECG is also important. In this patient, it was narrow QRS, but if you already have baseline conduction defect like left bundle or right bundle, and also the kind of TAVI prosthesis you're going to select. So we know that with self-expanding valve have got a higher pacemaker rate because they are implanted at a slightly deeper level. But in this case, as we saw during CT analysis, the height of the membranous septum was quite generous. So anyways, the risk of pacemaker was quite low. And now with that level of valve deployment, to be honest with you, I was surprised that he even had left bundle branch block. And as Dave pointed out, it is very likely that this left bundle might resolve in next 24, 48 hours.
Yeah, indeed, it was unexpected. But you saw that we noticed that even with the stiff wire in the LV, he developed LV block. So it might be a little bit sensitive. This is very important because of the young age of this patient.
I think there was another factor for that, and there was a component of regurgitation, a very large LV, and that's going to have a very good remodeling now because there is no PV leak. So this is going to help to less conduction disturbance. Typically in these dilated ventricles, we see more left bundle branch block.
Good point. Any other comments from you guys before we move to the next presentation?
I think the use of cerebral protection was very interesting and I think controversial. The purported benefits really unclear, and we wouldn't routinely use this in a low-risk patient like this, particularly with the bovine arch, and they said, we had some trouble getting it in, and that always raises sort of some concerns. So I thought that was an interesting element, that quite controversial. I think the left bundle is almost certainly transitory.
Okay.
Two things actually. One was the use of the LV pacing instead of the direct pacing for a balloon expandable, and that's why we don't use it. It's because sometimes we lose contact. For me, I would prefer to use, at least for balloon expandable, I prefer to use direct pacing. The other thing is, one thing about this Octapro Plus is the covered area of the stent is only about 6 to 7 mm supraannually. So for me, this would be very important from where I come from, where there are very many cases with very low-lying coronary arteries. Mm-hmm. So if we can use it for 6, 7 mm coronary arteries, that's why I kept on asking you about the coronary arteries, because that seems to be a lot of our problems, coupled with small annuluses. Yeah.
If time permits, I just wanted to highlight some good points from this case. So as we saw from the balloon inflation, it looks quite tubular, both at ICD level and annular level. And we saw on CT scan that this is what the pathology was. and there was no waste at all, which we normally see sometimes in tapered anatomy, that there is a waste in the balloon. Secondly, if you see the position of the guide wire, it's hugging the greater curvature of the aorta, which actually allowed the operators to have a very sort of a stable system, because this system sometimes does have tendency to dive down, and they were quite nicely able to control that just with the push and pull of the wire. There were questions about double tap. This is what double tap does. So if you see the image on the left-hand side is after the first inflation, and once they did the double tap, you can clearly see that the valve frame is far more in sort of a stretch, at least in the top half, thereby increasing the effective orifice area. But the most important aspect here is that this guy is 67. At some point, he would need another TAV in TAV. And therefore, it was extremely crucial during the CT analysis and during the procedure to ensure that we do have fairly straightforward options for TAV in TAV. And the good thing in this case is I've just drawn the coronaries just for the for sake of people appreciating it. But both the coronaries, left and right, they originate just above the stent frame, and therefore the risk of coronary plane is below the native coronaries. And that would allow the operators to put any TAVI valve in future. There is a lot of space on the left-hand side, so the VTC won't be an issue anyways, because the risk of coronary plane is below. And they've managed to got an excellent depth of, I would say, 2 millimeters. So this is a patient where future interventions are all possible. And this is what lifetime management is all about.
Okay, that was very important. Thank you. Thank you, Nishant. So now I invite the next speaker. We have a presentation from Salvatore Giordano, who will share with us the real-world experience performed at his place in southern Italy.
I'm the spokesman. I do a good job, but there's no question.
Okay.
So far.
Okay.
Good morning, ladies and gentlemen. I'm Salvatore Giordano, and I work at Pineta Grande Hospital. And today I have the pleasure to share with you our experience with the Myval THV series. Our journey began in February 23 with the Myval THV system, and since then we have consistently used it throughout the time with a total of 250 valves implanted. We use this device across a wide different spectrum of clinical scenarios. Most of the patients where we used it were above 75 years of age, although a few were remarkably younger. More than a half were female. 90% had a surgical risk between intermediate and high. And 98% of the cases were implanted in native aortic cannulus, whereas 2% in a degenerated prosthesis, either valve-in-valve or redo TAVI. A few of the aortic valves that we treated were bicuspid. Almost a third had a small aortic cannulus, while another third a large one. A few selected cases were performed via transaxillary route, and we used almost all the Myval THV sizes available, with about 40% being intermediate sizes. After the procedures, the mean gradient dropped to single digits, with excellent results in terms of paravalvular regurgitation. Technical success occurred in 99.6% of cases, with a pacemaker implantation rate of 17%. What is remarkable about the Myval THV series, beyond its wide range of sizes, is its predictability and precision in delivery, especially due to its small foreshortening and its navigability. To highlight this feature, I will quickly show you a couple of cases. The first one is a case of an 81-year-old lady who underwent TAVI in 2015 with a Edwards Sapien 3 size 23. She presents with dyspnea, and at the echo we could see the presence of a prosthesis dysfunction with a mean gradient of 40 millimeters of mercury and a moderate severe aortic regurgitation. You can see at the bottom of the slide the slices of the CT scan at the inflow, waste, and outflow, with a mean measurement of the area around 310 millimeters square. The ostia of the coronary arteries were right above the outflow of the degenerated prosthesis, and in this case, we need a device which could fit small annular, in this case prosthesis, at a short frame and at a precise and predictable delivery. That's why we opt for a Myval Octapro 21.5. As you can see on the left, the release of the Myval Octapro inside the degenerated prosthesis, we align the outflow of the two valves because the Myval has a slightly taller inner skirt compared to the Edwards. On the right, you can see the final result after a post-dilation with a non-compliant balloon, with a mean gradient that dropped below 10 millimeters of mercury. The second case is the one of an 81-year-old gentleman who presents with a symptomatic aortic stenosis and a highly horizontal aorta with a ventricular aortic degree of 75. Beyond the horizontal aorta, the patient presented also an highly tortuous thoracoabdominal aorta. So we needed a device that had a good deliverability. And we opt for a Myval Octapro. In this case, the size was 26. As you can see on the left, the device navigates smoothly through the tortuous aorta. In the middle, you can see the device properly placed and released despite the horizontal anatomy, and on the right you can see the final result. So there are several upcoming trials investigating the Myval THV series. One of them is the Start Young trial, which includes the patient that we've actually just seen from the live, from Toulouse, where one of the principal investigators is based, Dr. Cheche. In this trial, they investigate the surgical versus transcatheter aortic valve replacement in young patients. It is a prospective, randomized, multicenter, non-inferiority open-label trial that has the aim to show that the Myval THV series outcomes are non-inferior to the surgery in severe aortic patients aged 65 to 75. So 1,180 patients will be randomized to either of the two arms. The efficacy endpoint will be at 1 year and is a composite of all-cause death, any stroke, rehospitalization for valve-related events. The safety endpoint is at 1 month and is a composite of all-cause death, any stroke, BARC 3-5 bleeding, AKI 2-4, rehospitalization for a procedure-related event, or intervention for aortic valve dysfunction. It's planned a follow-up of 5 years. And there is also a sub-study, a CT sub-study that aims at evaluating the prevalence of feasible redo TAVR or valve-in-valve TAVR without requiring leaflet modification techniques, along with other secondary endpoints. And then another interesting study is the one conducted where the PI is Dr. Ignacio Santos, the Myval study, which is a prospective multicenter single-arm trial which for the treatment of severe symptomatic non or mildly calcified aortic regurgitation with the Myval THV series. 164 patients have so far been enrolled in approximately 25 centers, with a primary endpoint at 30 days consisting in a composite of several hard clinical endpoints defined by BARC 3, along with conduction system disturbances, moderate paravalvular regurgitation. In this case, there is a 5 years follow-up planned as well. Finally, this is a registry that we have designed, the MELA registry, which includes patients that underwent TAVI with a large aortic annulus and severe aortic stenosis. We enrolled a patient who underwent TAVI with the Myval THV series and Evolute R, and we compared early outcomes at 30 days. And the primary endpoint will be is a composite of moderate severe aortic regurgitation, new permanent pacemaker implantation, and unsatisfactory valve performance. The study is under submission. And this is a final slide to conclude with all the ongoing trials from Merrill. Thank you very much.
Okay. Thank you, Salvatore. So now I invite Markus Kassel with a presentation that goes beyond the horizon. So let us know what is beyond the horizon, Markus.
Yes, thank you for introduction. So my topic is what comes beyond the horizon, what has the company in pipeline, and perhaps what comes in the next years on the European market. These are my disclosures. So here is a busy slide with an overview about what the company is working on. So perhaps starting with the CT planning software, then they have developed an app, AI-based for procedure planning. They have surgical valve in their portfolio with a mechanical and also tissue valve. Then we saw a very nice case with the Myval Octapro Plus. And especially here, I like that the frame is very short, that the skirt is not this high, that the valve has not really a big foreshortening, what makes placement and precise placement, as we saw before, more simple. So besides the small Python sheaths, they have a real Python, the Python BC Smart sheath, what is much longer and has 24 French sheaths. The company has also occluders for treatment of congenital disease. They have also equipment for transcatheter crossing, flexible sheaths, plugs for paravalvular leak treatment, and finally also edge-to-edge repair system. So some words about the CT planning tool. The core lens. Core lens is not only for TAVI, as is shown here in the picture, it's also can be used for planning of mitral treatment, pulmonary artery valve treatment, tricuspid planning, and also left appendage planning. This is a picture about the app, what is created, and I think the app used is based on a data set of more than 20,000 CT imaging data, and has a high accuracy, and gives an overview about the anatomic challenges, and also is very helpful for sizing. So besides the wide range from the Octapro Plus, from 20 millimeter valve in small steps, 1.5 millimeter steps towards 32 millimeter, there's also a Myval XXL valve with the size of 32.5 and 35. So in the northern European countries, I think there is a real need for this, and also in the treatment of aortic insufficient valves, which are usually larger than aortic stenotic valves. We have the valve was first implanted in 2017, so means 8 years before. But this year there were 4-year data published, and the data so far look good, comparable to the competitor valves. the Python BC Smart sheath. It's a 24 French sheath with a 76 centimeter length. Especially here you can put multiple guide wires in the lumen of this sheath to make it stiffer and to overcome, for example, here a very tortuous aorta, and it looks like it works and facilitate then the treatment for this kind of problems. In congenital space also there is a Myval, there will be a Myval valve available, Myval Pulmo. So here in comparison to the Myval Pulmo has a 100% high inner skirt. It's also available in sizes from 20 to 32 in 1.5 millimeter steps. And here in addition, this long Python BC Smart sheath is very useful to really implant the valves in the pulmonal valve. As shown here, a pre-stented valve, and a very tortuous way towards this pre-stent, but finally with a good result. What we know all is balloon gliding, the watermelon seed effect, and also Meryl has here a solution for this. The Mammoth M-Boss balloon is available in multiple sizes. It's a non-compliant, more or less high pressure balloon. I think the rated burst of this balloon is 7 atmospheres, and the speciality is here it has a nitinol cage on the outside of the balloon, and this helps to stabilize the balloon in place, and also perhaps it could be used as for balloon valvuloplasty or valvulotomy. So finally, the edge-to-edge repair system. So it's not only the color what is different than the competitors of the system. The clip itself, it's also different. The closing angle is a bit wider, perhaps less traumatic to the leaflets, and gives less tension on the leaflets, what can help in durability of the procedure. And similar to the aortic valve, we have also more sizes, altogether 10 different sizes are available with this system. This system is approved in India at the moment, and there are 2 upcoming or planned trials. One big trial in India, the other is a worldwide trial, and with a follow-up over 5 years. This is my final slide. So also the company invested in the LVAD system, the RIDAY system, currently only used in animals, but with good data up to 60 days, as it's shown here on the right side. This is my last slide. Thank you for your attention.
So I think we are a little bit behind schedule, so we will be very short in the conclusion. I think that the future is bright, okay? The sky is the limit. I think that the other day when talking to the leaders, I was amazed by the fact that the bicuspid is still their target number 1, despite all these trials about young people, moderate, etc. So the case that we have seen from Toulouse is, as usual, impeccable.
Perfect.
I must say that I have watched so many live cases around the world. I really ask Mary Live to make a listing of that, because I've never seen something unpleasant. So clearly they should use all this video as source documentation and go for, I'm sure there is more than 100 live cases so far, so that will be a wonderful information. Very small comment. I think that clearly going in the 65-75, you were the most conservative because of your surgeon in the Netherlands, but it is a big challenge because that individual, 67 years old, without coronary artery disease, with a good ejection fraction, without comorbidity, okay, diabetes, but it doesn't have to pay the price on the coronary artery, may have a life expectancy of 84, 87. So that valve will have to resist 15 years, 20 years. In the Netherlands, we are now with 84, and worldwide, we gain every year in life expectancy 3 to 7 months. It's amazing to think about that. I mean, our generation probably will be in the 90s, 95, I hope so. But I think it's a real big challenge to see. But what you see in this meeting is that the durability of the mitral valve and the durability of the aortic valve is pretty reassuring, despite all the effort to develop something else. So as usual, it was a very exciting meeting. The fact that there is no question is a tribute to the speaker. They were clear enough so that there were no questions. Thank you very much to the audience, the panel, and the speaker, and the live kids.